Hello, it's Dr. Butzen. I'm back talking about reverse total shoulder replacements today. This is something that's very common in my practice. It's actually a really great surgery for the right patient. And so I'm here today just to go through this and explain how it works, why it works. Um, the thing about the reverse shoulder replacement you got to remember is that before this implant was invented, some of the problems that it solves were previously unsolvable. And so it's a really great advancement. Um, and, there are some limitations that come with that, but it's got quite a lot of advantages and things going for it. It's also kind of fortunate if you look back at the history of the reverse. Um, is that we're actually probably right now about, I'd say, third generation, fourth generation of real change. And so, right, we're really now seeing um, like a almost normal shoulder outcome, as opposed to some of the earlier generations where they were, still in the learning curve, trying to figure out how to get the implants to stay without loosening or with restrictions, real restrictions in range of motion. So really, it's nice to be kind of on the other end of it, where we're actually seeing a lot like good motion, good range of motion, and much better longevity than we used to see. So first of all, what is a reverse shoulder replacement? Here you can see, a normal shoulder looks like this. This is the shoulder blade over here. Here's the socket, and the ball is on the humerus bone. This is the humerus. When we do an anatomic shoulder replacement, essentially that's for osteoarthritis or wear and tear to the joint surface of the shoulder. What we do is we put a plastic liner to replace the socket. So this is actually plastic here, and then there's metal that goes on the humerus with a little stem that goes down, or there's newer techniques than this now with a stemless. Um, but essentially the head and gets replaced, the bony head gets replaced with a head, and the bony socket gets replaced with plastic socket. So we're keeping the shape, we're just resurfacing it. And then of course this is the reverse. Now this is totally different, right? Where there used to be a socket here, there's now a metal plate with some screws, different of course implants now than this drawing or this picture here, but a ball is attached to that socket. So we took the socket off, put a ball in its place, and over here same similar kind of stem that goes down, but this is a socket, and there's a plastic liner there that you can't see there either. And so we're putting the ball where the socket was, and we're putting the socket where the ball was. Um, Typically, the reason you would do this is a rotator cuff problem, right? And so this middle one here is really the main thing, and this is how this got invented. Was previous to this implant, if someone had a rotator cuff tear, and the downside to the cuff tears is they don't always hurt, and you may not know it's there until it's too late. And then if a cuff has been torn for a long time, it can atrophy, and once it atrophies enough, it's no longer fixable. Or if you try to fix it, it tears again. So previous to this surgery, there wasn't really a very good solution to that. Um, and so that's kind of that's kind of the main thing. Now, when we do an anatomic shoulder replacement nowadays, especially since the reverses are so good, what we do on an anatomic now is I always get an MRI of that just to see what's the condition of the rotator cuff. Because if the rotator cuff is perfectly fine, yes, you could do the anatomic. But if the rotator cuff is tearing, or if there's even just the earliest stage of a tear, the concern would be that if you did the anatomic shoulder replacement and then the rotator cuff tore, well, then you have to go and remove all of this and put this in. And of course, that's where, again, that stemless implant is easier to get out than this huge stem here. So, but anyway, one of the main things is to make the best choice from the beginning. And a lot of times, if they have arthritis, depending on the condition of the rotator cuff, right? So arthritis of the joint is where the surface is worn. You say, all right, well, you need a new joint. Should you do an anatomic or should you do a reverse? A lot of times the cuff decides that, or just the fact that it, even just like the idea that it could tear. The other thing we use it for is these complex humerus fractures. What's common, and it's, this is its own topic. We don't need to go into the details of this, But the problems that happen from these humerus fractures, and what it is a fracture through the humerus here. Again, this going back to the rotator cuff, what happens in those fractures is that the cuff, the rotator cuff doesn't tear, but the bone that it's attached to fractures. And if that bone doesn't heal, it's just like a cuff tear. And so if the bone doesn't heal after a fracture, you're basically living with a cuff tear. And so a lot of times now we'll just do the reverse from the beginning because we don't have to worry about that. The cuff heals, doesn't heal, whatever, you still have the reverse in there and that can move. So how does it move? This is a little trickier thing too to explain, but essentially, and these two drawings aren't even the same scale, but essentially when you move a ball and socket joint, the center of rotation is important to understand. The center of rotation is the center of the ball. So when the humerus comes up and the center of the ball is at the humerus, that's quite a ways out. It's outside. The main power of the shoulder is the deltoid muscle. And so the distance from the deltoid to that center of rotation matters a whole lot. The reason why when you tear the rotator cuff, and the supraspinatus is kind of the main cause, you tear that supraspinatus coming over the top, you can imagine a big hole there. The deltoid's force is pulling almost perfectly vertical. And so when you have a torn rotator cuff, the deltoid is working. It's a very durable muscle, but it's mostly lifting the humerus up. And in some cases, it'll lift the humerus up until it hits the underside of this bone, and this is the acromion, and then it'll swivel out on that. And that's an okay way to live. It's just not a great long-term plan because then you get, wear and tear between these two bony surfaces, and there's no real joint there. It hurts, and sometimes the humerus will eventually kind of dislocate, and it just won't work. So by taking and putting in the reverse, and this, like I said, this is not to scale, but now instead of the ball, the center of rotation being the center of the ball, it's actually now moved inward. And that helps to give the deltoid, it's just a little further away, which gives it a little more leverage. Leverage is, kind of like the force that's perpendicular to the distance. So it's a kind of a, physics thing where you got to figure out the torque or the, force there. But essentially by moving the center of rotation inward, it allows the deltoid to have a little more of a rotational force as opposed to a straight lifting force. At the same time, we put the socket at a 45-degree angle. And there's different angles, and I've tried different things for different reasons, but 45 degrees seems to be a really good choice. And so when that deltoid has still a lot of lifting force, but because that socket is tilted, it's actually helping it as the socket goes up, it's swiveling around that ball. And so when the supraspinatus is torn and there's a big hole there and it can't really fill that space or hold that head down, the reverse essentially fixes that problem. It's really a good way to go. So this is more or less like a modern reverse. I like this design. It's got a base plate. This shows it the best. There's a base plate on the socket. There's 5 screws, one big central screw, and you can really crank it down. And then smaller screws around that to stabilize that. The metal itself has a grit blasted surface or a really coarse surface that your bone will grow into over time. And the screws hold it while that growth is happening. The stem, of course, I do still like a kind of a longer stem. I've experimented a little bit with shorter stems and have had a little bit of loosening. So I do like this. It's much more durable. But you can see that 45-degree or 135-degree neck shaft angle that supports that. And the socket is actually embedded into the humerus just a little bit, which helps to lateralize that center of rotation just a little bit, enough to really kind of fine tune that deltoid. And this shadow right here is the shadow of the deltoid. So this is the implant. I think this looks really good. So the process to undergo this surgery, first we got to make sure you're safe to do so. A lot of times this is an outpatient surgery with an option for an overnight stay. And of course, we really kind of have to comply with keeping sick patients, but not, everybody. So what we end up doing is kind of stratifying people based on risk, because we really want to, like, if people need to be observed, we like to observe them. But generally speaking, this can be an outpatient surgery. In most cases, it is. For pain management after surgery, which I really kind of like to think that the pain from surgery is about a week. We do what's called multimodal pain relief. So this is trying to hit the pain from a lot of different directions. The first is a block. The block is just an injection that's given kind of at the base of your neck where the nerves are coming out. We do that on the morning of this, the day of the surgery, before the surgery. So we're even blocking your pain during the surgery, so we can hopefully go a little lighter on the anesthesia. But we do it in a way with a catheter, and the catheter is just a plastic tube that drips medicine for 3 days. So we get a 3-day block out of that. Ice really helps. Ice is an anti-inflammatory. There's a thing called an ice machine, which makes it kind of automated, and that's a nice thing to consider. And then pills, Tylenol, an anti-inflammatory. We usually use Celebrex, although that's flexible. And then a narcotic. And the narcotic is definitively the third option as far as the pain pills go. Oxycodone, probably the most commonly used one, but there's a bunch of them out there. And for the most part, people do very well with this. Sometimes, not even taking any oxycodone whatsoever. Typically, that first follow-up is 2 weeks after surgery, with me regularly seeing me or my team, coaching you through the whole process for a few months. Typically, this is a guy who had his right shoulder done. He's really happy about being able to hunt. You immobilized. I really just like to keep people in a sling for 2 weeks. I know a lot of other surgeons have different preferences. I've been doing this protocol for about 10 years without too much trouble. I haven't honestly had any, problems with loosening or anything from being too aggressive. And I've actually avoided a lot of the stiffness that I used to see when I had a longer protocol. But I can't remember exactly when I started doing this protocol, but it's been at least 10 years. We also start physical therapy right around 2 weeks. And that, the idea is, you get out of the sling, you start using it. Light activities are great. And then therapy coaches you to kind of push you along a little bit. The range of motion restoration, that's our primary goal. Stretching, and I usually show you some exercise, but PT plays a big role in that. And then, as you tolerate, as your range of motion improves, as your strength improves, you can definitely progress. Some surgeons have preference or have restrictions, permanent restrictions. I really don't. I really just tell people to avoid repetitive impact type activities, and that's like splitting firewood by hand, running a jackhammer, that sort of thing. We always talk about that. Typically, people are most of the way there by 4 months, but the strength really takes a long time, and I really kind of say up to 2 years for restoration of your strength. But for the most part, people feel like it's a normal shoulder, don't think about it on a daily basis, and just get back to their normal activities right around 4 months. All right, thanks. And that's, reverse total shoulder replacement. Please let me know if you want to come in for a consultation. I'll tell you everything I know about this stuff. I love talking about it. If you have any ideas for other videos that you're interested in, feel free to send me an email. Feel free to send me a text message or leave me a message. And I'll see you on the next video.